Didn't mind capture this one for the recording. This mic. Okay, Bismillahirrahmanirrahim. Please get settled. Let's begin. Okay, very thin attendance. Why? Any exam coming up? Okay, so today we have actually two lectures. We're going to cover the renal area. The purpose of these lectures again is not to make you masters of this subject, just to give you a basic idea what investigations are there for the renal system and how would you investigate once you are in the ER or once you have a patient with the renal abnormality. So the basic idea is so that you know what sort of investigations to order and what to expect. Okay, so we have these 6 modalities. Conventional radiography is actually X-rays. The X-rays, simple X-rays that we do for evaluation of the KUB, that is kidney, ureter, and the bladder. What is IVU or IVP? Does anyone know what is IVU and IVP? Intravenous, urogram, or pyelogram? Yes, we use contrast with the X-rays. So it's actually, again, X-rays with addition of contrast. And we do a sort of serial evaluation of the KUB area just to see the function of the kidneys, because we don't get information about the function of the kidneys unless we inject contrast. Okay, once the contrast goes inside the body, it will be accumulating inside the nephrons, and then it will be excreted by the nephrons into the collecting system, and then it will come out and outline the urinary bladder and the ureter and the pelvis. So if we are trying to see the function of the kidney, we need to use contrast. So we'll see how it looks like and what is the advantage of IVP. Ultrasound, you're all familiar with. Sound waves we use to value. It's not only in the renal system. Ultrasound is used everywhere in the body, in the abdomen, even in the soft tissues and MSK. So it's a very easily available modality. So you can evaluate different structures without any risk of radiation, or it just needs a little bit expertise of that area. CT is contrast. You can use contrast with CT, but again, the problem is the radiation. The dose of radiation is the maximum in CT scan compared to any of the other modalities. In X-rays, in IVP, in nuclear, there is all involved radiation. The dose of radiation in CT is about 5 or 6 times more as compared to IVU. So you can just imagine how much radiation is being given for a CT scan. So CT scan is usually not done unless it is really needed. And the time when it is needed is going to be the trauma cases, because the information that we want in cases the patient is in bleeding inside, or there's a trauma or fracture or a visceral injury, then we need to have immediate information. So we are going to save time just to, for that, we cannot, depend on MR, because MR is going to take more time. And it's not easily available in the ER setting. So whenever we have a trauma case, remember, investigation of choice is going to be CT. Why? Because it's going to give you all information about visceral injury, about fractures, about internal bleeding, whatever information. MR is, again, the advantage of MR is it doesn't have radiation. We use the magnet. And the problem with MR is it is more time consuming. You need to prepare the patient. And if the disadvantage is, it is, it doesn't show up stones, because stones would be appearing black on all sequences. It'll appear dark. So sometimes you cannot pick up the stones easily on MR. So as far as MR is concerned, usually done for soft tissues and for tumor evaluation. And we make use of contrast as well. Okay, so does anyone know what contrast we use in CT and MR? Iodine, okay? So the contrast that we use in CT is going to be iodine, whereas in MR it's going to be gadolinium, okay? Okay, nuclear medicine is, again, we use a tracer, we inject the tracer inside the body, inside the blood, and then it goes and sort of concentrates inside the kidney, and it outlines the kidney again, the same information. The advantage of nuclear medicine is it's a functional study. So you are able to tell whether the kidney function is normal or abnormal. A great advantage of nuclear is you are able to give a differential sort of functioning. Like you can tell how much the left kidney is functioning, how much the right kidney is functioning. So you'll have a sort of graph which will tell you which one is right and which is left. And from that graphs, you can calculate, for example, out of 100%, this kidney is 40% functional, whereas the other is 60% functional. So this sort of differential function evaluation is possible through nuclear medicine, which is not possible in any of the other imaging modalities. So we'll see this how this all functions. So this is how the X-ray machine looks like. You're all familiar with this. Patient lies there. There's a cassette. This is the old days. Now you have these, like in the digital cameras, you don't have those films developing, but the same information that you get on X-rays. Remember, the radiation dose is the least in cases of X-rays. Why do we still use X-rays? Why not just give up X-rays? Cheap, okay. What else? Good for fractures, okay. What else you want to rule out when you're looking for the kidneys or for the stones? Okay, so the information that we are more concerned about is the stones. So how much stones are radio opaque or easily visible on X-rays? How much percentage? Anyone? Any clue? Okay, not visible. Agree. So I'm asking about the percentage. How much out of say 100% or 10 stones? How many would be visible out of 10? How many would be visible on X-rays? All 10. 90%. Okay. So that is why we are still using these X-rays. If they were not visible, we would have left X-rays long time ago. Since 9 out of 10 are still visible, that is why we are still using the X-rays. So remember, when you are evaluating with the X-rays, we also need to have good preparation. Why do we need good preparation? Because we don't want these renal areas obscured by the fecal matter lying in the colon or in the stomach lying in front of it. So for X-rays, there's a problem with the preparation. So you need to have the patient at least 4 to 6 hours fasting. Sometimes we also give them Dulcolex tablets just to get rid of the fecal matter inside the colon. Okay, so overnight Dulcolex, and we ask them to take liquid diet, and then sometimes 4 to 5 hours fasting, but we don't hold the liquids. The fluid and water is not stopped. Okay, so the hydration is not stopped these days. Okay, so the stones that are not radiopaque: uric acid, cysteine, and matrix stones. So they make up around 10%. Okay, this is the composition. Remember, the stones that are visible are going to be the calcium stones. So by far, the majority of the stones are going to be the calcium stones, 80% of them. And that is why they are visible. Calcium can be in any composition. They can have other components like magnesium, calcium, phosphate, calcium, ammonium. They can have a sort of mixed picture with them. What is true white stones? Again, they are composed of magnesium, ammonium, and phosphate. Okay, so they have these 3 components. They are also radiopaque. So if you put them together, 80 and 10 means 90% are going to be radio opaque. So that is why we are able to pick them up on X-rays. Whereas uric acid stones, cysteine stones are going to be radiolucent. So these are the ones that are not going to be seen on X-rays. So what are you going to do then? CT is a good choice, but is there anything better than CT? Ultrasound, yes. Start off with ultrasound. Why? Because obviously there's no radiation in that. So ultrasound can show you all 100% stones. Why? Because remember, it's the other way around in the gallbladder stones. Why the gallbladder stones are not radiopaque? Cholesterol, yes. They are made up of cholesterol, so they are not radiopaque. So it's the other way around. But even the gallstones are picked up on ultrasound. That is why you ask ultrasound for gallstones, never an X-ray for gallstones. Have you heard of anyone asking an X-ray for gallstones? So that is the reason, because they're not going to be radiopaque. So by far the majority of renal stones are radiopaque. That is why you ask for an X-ray. Okay, got an idea now? But all these will be visible on ultrasound. Why? Because ultrasound is just sound waves. So anything which is going to hinder the sound wave, and obviously any stone is a firm thing, is a hard structure, so it's going to reflect the sound waves. Even if it is made of cholesterol or whatever material, it's going to reflect the sound waves. So they'll appear on ultrasound. Got an idea? Basic idea? Okay, so IV view or IVP is the X-rays taken with contrast. So you inject contrast and then you do serial films, say after 5 minutes, 10 minutes, 30 minutes, depending on the excretion of contrast. The problem is again the radiation dose. You have around 3 millisievert. If you compare it with CT, it is less than CT. CT is around 15 to 20 millisievert. You need good hydration preparation. As I've already mentioned, we don't want those fecal matter shadows lying in front of us. Okay, the contrast that we use is iodine. It is low osmolality. The iodine that is given is, some people are, hypersensitive to the iodine. You know of anyone who is hypersensitive to iodine? Any conditions or any food? When we ask for IVP, we take a history of seafood. Yes, iodine is going to be in the fish products. Yes, it's also going to be in the eggs. So the persons who are unable to take egg or fish are not going to be injected with iodine because they will develop a reaction to iodine. So we need to prepare these patients before we inject iodine. So sometimes we give them steroid preparations before actually injecting iodine. Okay. Likewise, some people are asthmatic, so we'll prepare the asthmatics also. Any one who is hypersensitive or has a previous history to the contrast reaction or previous history of contrast reaction, we'll prepare them before giving iodine. We'll not give them iodine immediately because they'll develop a reaction. Now the reactions can be mild, moderate, and severe. The severe ones are going to be the ones that can land up this patient in the ER because they will develop glottic edema. Then obviously sometimes you could need to intubate them or give them adrenaline or whatever, for resuscitation. So we don't want that to happen. Okay, so hypersensitivity to contrast media and renal impairment. So if the patient is already having renal impairment, like the urea creatinine levels are high and the GFR is say less than 30, would you be giving him contrast? You should not be giving. Why? Because this contrast is going to sort of concentrate in the nephrons, and from the nephrons it's going to be excreted into the collecting system. So if the functioning of the nephrons is already compromised, why would you give iodine? It will retain inside the nephrons and do further damage to the nephrons. So we don't want that to happen. The same information that the drugs that are excreted by the kidneys, you will not give those drugs. Okay. So this is how the IVP looks like now. If you look at it, you can see the outline of the ureter. You can see the bladder here. You can see the pelvis, the collecting system, the upper pole calyces, the middle and the lower pole calyces. There's cupping, normal cupping of the calyces. Okay. So any abnormality in the collecting system can be picked up by IVU. So it's good for the evaluation to see the function of the kidney. Okay, so let's talk a little bit of now ultrasound. As I've said, it is easily available, just requires a little bit of expertise and you are, good to go. You can evaluate the kidney, the bladder, the prostate. The only problem is the ureter, because sometimes the ureter is a very thin structure, 2 milli or 3 millimeter diameter structure. So if there is bowel gases around it, you'll find it difficult to visualize the ureter unless there is hydronephrosis. If it's dilated, hydroureter, then you can easily pick it up. Okay, so that's the only area where there's some problem. Otherwise, kidney and the bladder and prostate are easily seen with ultrasound. This is how the kidney looks like on ultrasound. This is the adjacent liver. Now, if you look at or compare it with the liver, the echogenicity or the appearance of the cortex is darker as compared to usually the liver. And why this area is brighter? Why is the medulla brighter here? Why the cortex is black? Anyone? What structure makes it brighter in the center? Fat. Okay. So it's sinus fat. This is the fat inside the medullary region. That is why it is brighter here. Okay. So ultrasound is very good for parenchymal changes. So any renal functional abnormality, you were able to pick up these parenchymal changes in diabetic, in hypertensive patients. Once the kidneys get affected, you can pick up those early changes. You can also pick up hydronephrosis. You can pick up renal cysts, mass, and you can also, with the help of Doppler, evaluate the renal arteries. So you can pick up renal artery stenosis or anomalies of the arteries. So just keep in mind how the kidney looks like. Remember the cortex, and there is a medulla. So we'll see this how the cortex and medulla are actually differentiated in the later images. Okay, so CT. Let's talk of CT a little bit. As I've said, trauma. It is usually required in cases of trauma because we do not have that much time. If the patient is bleeding inside and we suspect any injury to a viscera, specifically to the kidneys, then we would ask for a CT scan. And we could also do CT for stone, infection, congenital anomalies, and angiography. Angiography means to evaluate the renal arteries and renal vein, any thrombosis inside. So CT is a very fairly good choice, but the only problem is the radiation dose. This is the problem. The excessive amount compared to any of the other modalities, the radiation dose is the maximum. So we are just bothered about this. Okay, so this is how it looks like. The kidneys is a retroperitoneal structure. So you would see aorta, the IVC, and the kidneys, the perinephric fat, the psoas muscle. So all these make up the retroperitoneal structures. We'll also see some part of the pancreas, the duodenum also in the retroperitoneum. MR, again, the same information that you get through CT also you would get with MR, but it will take more time and it will just not show up those stones inside. Why? Because they'll appear black on all sequences. So unless they are big in size, you will not be able to, the small stones would not be able to, you will not be able to pick them up. But it is very good for infection and tumors, especially for tumor staging. And once you give the gadolinium, the contrast, you are able to outline the tumors and infection very nicely. So it's same information that you get. A problem with the MR gadolinium contrast is this condition, which is known as nephrographic systemic fibrosis. So the patients who have acute renal failure or have glomerular filtration rate, that is the GFR below 30, they are prone to develop this condition, nephrographic systemic fibrosis. It's a life-threatening condition. It's a dermatological emergency. So we usually do not want this to happen. That is why we ask for urea creatinine levels, especially middle and old age, where we suspect there is renal impairment. So remember, any patient with acute renal failure or with GFR less than 30, we should be suspecting this condition. Therefore, we should not be using gadolinium. Okay. Nuclear medicine, I've said already that it gives you the functional information. You are able to evaluate the function of both kidneys. It will tell you how much percentage the right is contributing to the excretion and how much the left is contributing. So for example, if the surgeon wants to know which kidney to save first, which is the more healthier of the kidneys, so this is the imaging modality he'll ask for. And you can tell him, okay, this kidney is functioning 70%. This is functioning only 30%. To try to save this one first. Okay. So this is once it comes to saving a kidney, nuclear medicine gives you that functional information, and you can separate the function, whether it is right more functioning or left more functioning. The isotopes that we use are going to be depending on what we are trying to evaluate. For example, if we are trying to just evaluate the morphology of the kidney, like if we just want to rule out scarring, we'll use a DMSA tracer. If we want to see the function of the kidney, excretion of the kidney, we'll use MAC3 or DTPA. These are different tracers that we use. So depending on what we are doing or what is required, we'll use that tracer. We inject that inside, it goes and concentrates inside the nephron, and then it is the same way like in IVP, it is excreted. So what images you get something like this. You see the initial blood pool phase, and then the later phase, you have the tracer accumulating inside the nephron. So the kidneys become black, and slowly and gradually, you see they start fading. The tracer fades off. So that means it's being excreted. So you see the tracer now in the urinary bladder here. You don't see the tracer here in the initial part. The same way, like in IVP, it is excreted, and then you are able to tell what is the function of the kidney. The advantage here is that you get these two graphs, the right and left. So you have a differential graph. You are able to tell how much the right is functioning and how much the left is functioning. So initially, once the tracer accumulates inside the kidney, so you'll see a peak like this. And once the tracer is excreted, you'll see a downfall in the graph or in the curve like this, and it will go like this. But if there is retention of tracer, non-excretion of the tracer, it will become a flat line like this. Okay. So instead of being excreted, it will remain inside the nephrons. So you'll have a flat line like this. Okay. So this is an abnormal graph. Okay. So this is what I'm referring to. So you are able to tell how much which kidney is taking up contrast quickly and which is excreting earlier. So that tells you about the function of that kidney. Okay, with this background knowledge, now let's put this together, see a few cases before we go into the actual cases. Okay, so this is an X-ray of the abdomen. We have covered the KUB area. We have the kidneys here. This is in the lumbar region. The ureter is supposed to lie overlying the transverse processes, and the bladder is here. Do you see them? You don't see them. Or do you see them? You don't see anything. You don't see the kidney, you don't see the ureter, you don't see the bladder, but you know that they are there. Okay, from the X-rays, you know that these structures are lying there. You don't see them. Why? Because they are soft tissues. So if there is a calcium here, it'll appear. Okay, so if there's calcium here anywhere in the collecting system, it will appear. But the problem is this. What do you think is different from this? Gases. So if you have gases overlying in the colon or the fecal matter retained inside the colon, that is the problem. That is going to make it difficult for the calcium to appear. So we don't want this to happen. Okay, so especially if we are doing the IVP study, we don't want this to happen. So you see, this is how once you give the contrast, you see the gases are still making it difficult to see the ureter, but still you are able to make out the collecting system, the ureter, and the urinary bladder. What is this image? How did we get this image? CT, yes. So you see the same information that you got through IVP, you can also get it through CT. In the excretory phase, you can get this, if you image the kidney or the collecting system through CT, you'll get this. And this is known as 3D reformations. So what we are doing is we are getting rid of all the extra stuff like spleen, the liver, you are not able to see them. So we are just focusing on that part which we are concerned about. So you can see the kidney, you can see the collecting system, you can see the bladder. All rest structures are removed, or through the computer, we just get rid of all those other structures. So this is very good information that you can get through the same information that you were getting through IVU, you are getting through CT. So that is why these days you hardly hear anyone being asking for IVU. So we don't usually ask for IVUs these days because the same information you get through CT. Another advantage of CT is with the contrast, it can also outline the renal arteries and renal veins, depending on what you examine. So this is this information of the renal artery is useful because in hypertensive patients, sometimes you could have renal artery stenosis either at the ostium or in the distal part. If it's fibromuscular dysplasia, it will be the distal part. If it is atherosclerotic osteal calcifications or stenosis at the ostium, usually in the middle and old age, you'll find the narrowing at this part, at the origin of the renal artery. So renal artery stenosis, you can easily pick up on CT angiogram. The same information you can also have through ultrasound Doppler, but it requires a little more expertise, okay? Another information you can get is any accessory arteries, especially in the ones who are to undergo transplant. The surgeon wants to know how many arteries are there so that he can do the anastomosis, how many veins are there. So any anomalies or congenital anomalies related to the vessels, you are able to tell through CT. Even a layman can, make up how many arteries are supplying this kidney. Okay, so this is what we saw initially. As I said, the central part is white. Why? Because of this sinus fat. The yellow is the fat. That is why you have this bright areas. Now, if you if you concentrate, you can also see the cortex and the medulla, the pyramids. The darker pink areas are the pyramids, and these are the papillae. If you are to measure the cortex, it should be from the hair to the base of the pyramid, like this. From this is the cortex, the pink one. If you are measuring the parenchyma, that means you are measuring all of it from here to here. Okay, so it depends on what you are measuring. If you're just measuring the cortex, it's from here to the base of the pyramid. Okay. Okay, so this is to show you how when the kidney becomes diseased. This is a normal looking kidney. You can make out the pyramids, you can make out the cortex. Okay. Now, if you lose this differentiation between the pyramids and the cortex, so we say loss of corticomedullary differentiation. So you see, it becomes difficult to differentiate between the pyramids and the cortex. And you see the thickness of the cortex is also reduced. So as disease progresses, or in diabetic or hypertensive patients, the nephrons lose their function. So the kidneys become smaller in size with time, and the thickness of the cortex reduces because the nephrons are disintegrating. Okay. This is a sort of another case where the disease is further advanced. You see again, the cortex has further reduced. And here, this is end stage disease, where there's a very thin tissue of cortex here now, a rim-like structure, which is the cortex, and rest is the medulla. So all nephrons are gone here. So that is why this is end stage disease. This is how the normal looks like. And if you look at the end stage, the kidney has shrunken, has become smaller in size, and you hardly have any cortex remaining there. So the kidney is not going to have any function. So normal, early stage, middle stage, end stage. This is how it looks like. Okay, now let's put the background knowledge. What is this? Anyone? Someone said something. What is this? This is all communicating. Pelvis. He's right. This is pelvis. This is calyces. This is middle calyx. This is lower calyx. This is upper calyx. The calyces are dilated. So what is it? What does it mean? Hydronephrosis. So this is hydronephrosis. All calyces dilated and the pelvis dilated. You don't see this in normal kidney. Did you see this in normal kidney? There's no hydronephrosis. So why would you see dilated collecting system in a normal kidney unless there is obstruction? So this is hydronephrosis. What is this? Cyst, right? It is round structure, and you see the sound waves are easily passing through it because of the fluid inside. Fluid, remember, in ultrasound is always jet black. Okay, fluid is always black. So fluid inside, the sound waves easily pass through. That is why you have posterior enhancement here. Okay, it's the other way around in cases of stone. There's a stone here in the lower calyx, and the sound waves are not allowed to pass through. So you have a shadowing, a black shadowing or a caustic shadowing, because the sound waves are reflected back. They don't pass through this. That is why you have a black shadowing here. And in cyst, it's the other way around, because they easily pass through the fluid. In fact, they pass more quickly through the fluid, the sound waves, that is. What is this? Polycystic kidney. You see there are multiple small cysts of variable sizes, and you are unable to differentiate between the cortex and the medulla. You don't see any cortex and the medulla. So this is polycystic kidney disease. This is just a solitary cyst. This is hydronephrosis, and this is a stone. Clear on this, everyone? Easy to differentiate. I hope you can now, once you see anything abnormal in the kidney, you are able to tell what it is, because this is by far the majority what you are going to see. Okay, so let's talk of the retroperitoneal structures. We know the duodenum, the descending colon, ascending colon, pancreas, some part of the duodenum, IVC, aorta, kidneys, adrenals, ureters. These are all retroperitoneal structures. Disease in the retroperitoneal structure is going to be limited to the retroperitoneal. It's not going to spread to the abdomen. Why? Because there are these fascias around it. So these fascias, perirenal fascias, that limit the disease around the kidney. So by nature, the disease process is going to be remaining there out in the retroperitoneum. Now let's see how these fascias look like. Here I've drawn it for you. The anterior one is the blue one is the Girota's fascia. The posterior one is the Zuckerkern fascia. This one is the lateral conal fascia. Don't need to remember the names. Just remember these are perinephric fascias. So what is their purpose? Just to, by nature, to limit the disease. So the fat around that is the perinephric fat. So whenever there is disease inside a kidney, there's infection, the infection remains around in these, within these fascias. It doesn't go into the abdominal cavity. So by nature, this is a way that the disease process remains in the posterior part. Okay, so remember these contents in the retroperitoneum. We've discussed this: kidney, adrenals, ureters, perinephric fat, limited by the renal fascia. Anterior one is the Girota's fascia, and the posterior one is the Zuckerkern fascia. Now, let's see this CT images. This one is without contrast. You see there's no contrast inside the aorta and IVC, and there's no contrast in the collecting system. So once you do a plain study, the purpose is to just to see any stones, okay, any stones in the kidney. Once you give the contrast, this is the corticomedullary phase. You can see the cortex and you can see some part of the medulla, which is not taking up contrast. So the contrast is outlining the cortex, and the contrast is still not reaching up to the medulla. So it's initially in the cortex. So this is known as corticomedullary phase. Remember, if you image before 90 seconds of injection of contrast, it's going to be corticomedullary phase like this. If you image the kidney after 90 seconds, it's going to be nephrographic phase like this. So now the contrast is also going to reach the medulla. So you'll see that the cortex and medulla, you are not able to differentiate between the cortex and medulla now, because both would take up contrast and look homogeneous. So usually the tumors that we are looking for in cases of renal tumors, we are more concerned about the nephrographic phase, okay? We are more concerned about the nephrographic phase. Now, this is the excretory phase. You see that the contrast is now inside the renal pelvis and calyces. So it's in the collecting system. The excretory phase is usually after 5 minutes. So say after 5 or 10 minutes, if you examine the kidneys, the contrast, examine the kidneys after injection of contrast, the contrast is going to lie inside the collecting system. What is the use of this? The same use that you saw in IVP. It will outline the ureters and the urinary bladder and the pelvics and the calyces. So any tumor inside the collecting system, like transitional cell carcinoma, like a stone inside the ureter, you'll see that giving you a filling defect inside the collecting system. So we'll see this in the next coming lecture, inshallah. We'll see more examples of this. Okay, so we discussed plain urogram. The first one, this one, just for stones. Corticomedullary phase, usually you are able to scan before 90 seconds of injection of contrast. This is usually done if you are suspecting something in the initial phase, like the early arterial phase enhancing tumors. Then we use corticomedullary phase. Nephrographic phase is the later stage, that after 90 seconds of injection of contrast. And excretory phase, I've said, is the delayed after 5 or 10 minutes. The same area, you can, if you examine after injection of contrast, you are trying to evaluate the collecting system. Same information you can also get in MR, the corticomedullary phase, and you can get the nephrographic phase depending on, but the contrast is going to be gadolinium. The same thing applies also for MR. Okay, so we'll evaluate, these are the things which we are going to see. These are the common conditions that we are going to see, which are by far the majority of the times the pathologies that are, required for you to know in the renal system. So stone disease, renal infection, congenital anomalies, renal masses, renal trauma, and some few miscellaneous conditions like, scrotal masses or a few other testicular masses. So we'll talk of this. So the first three we are going to focus on today. Then the other three we will focus on, inshallah, in the next lecture. So male patient with left flank pain, hematuria, no fever, and normal WBC count. So what do you think is wrong with him? Stone. Obviously, he has renal pain and there's no fever, which is against infection. Okay, so he has multiple stones in the left kidney. You can see this is in the renal pelvis, taking up the shape of the pelvis. This is in the upper pole calyx. There are multiple stones in the lower pole calyx, okay? So if I were to give you only this image, this X-ray, would you be able to tell me how many stones are there? You cannot tell me. Why? Because this is an excretory phase. You will tell me that there is something abnormal. These calyces are dilated, these renal pelvis is dilated, this ureter looks dilated. Compare it with the other side, which is normal. So you'll tell me this collecting system is highly abnormal, but you cannot tell me how many stones are there and what is the reason for this dilatation of the calaceal system. So remember, whenever you are looking for a contrast study, always ask for a plain study if it's abnormal. If it's normal, then obviously you don't need a plain study. You'll tell him, oh, it looks normal. So once you see an abnormal contrast study, always ask for a plain study, because there are times where you can miss out these stones. So never read in isolation a post-contrast study. This is a CT showing you again a stone in the pelvis. This is a stone inside the urinary bladder. On ultrasound, the same stone looks something like this. It has this acoustic shadowing behind this. As I've said, sound waves do not pass through. So that is why you have this dirty black shadow behind it. It's the same dirty shadow behind this, but this time, this is stones inside the urinary bladder. You see, these two stones are lying inside the urinary bladder. Why are the bladder stones larger? Why do you think they get larger in size? It's a reservoir, so there's more sedimentation and deposition of the material there. So the stones remain there for even years and get larger in size. Sometimes they can even fill up half of the capacity of the bladder. So people remain sometimes asymptomatic. Okay, so these are bladder stones. That is why they are big in size like this. Sometimes you just, see them and you are able to tell them that these are stones. But sometimes you could also have calcium in the wall of the urinary bladder like this. So why would you have calcium in the wall? Infections, any infection, cystitis, any cystitis, usually it is the parasitic infections like schistosomiasis. The parasitic infections result in calcium deposition inside the urinary bladder wall. And if you do a CT, you'll see the calcium like this. You see, this is calcium of the wall in the wall of the urinary bladder. How is it different from this bladder? Compare this bladder with this bladder. What is the difference? This one has calcium. But what about this one? Does it look a normal wall? It looks thickened. It looks thickened, but it is soft tissue. Compare it with this recti muscles. See, this is soft tissue density. So when you have thick wall, bladder wall, which is soft tissue, this is the condition, cystitis. Infection, initially, you will not have calcium deposition overnight. First, you would have cystitis, and then you would have deposition slowly and gradually. So cystitis, when do you have cystitis? In females and males, do you know of? Females have more cystitis in young age. Why? Because the urethra is small. So they are more prone to develop infections. In adults, in males, it's going to be in the later age when there is prostatitis and hyperplasia of the prostate. They then have retention of urine and then they have recurrent infections. Okay, so cystitis in females is more common in the early age, whereas in males, it is in the later age you have cystitis. Clear on this? So this is how the cystitis would look like on CT. You would have thick wall. Even if you do an ultrasound, you see that the wall thickness is more than 3 or 4 millimeter in thickness. Okay, so there's a stone in the ureter. Okay, and what is it doing? It's resulting in hydroureteronephrosis. Ureter is also dilated, and the collecting system, the calyces and the pelvis, all are dilated. Look at this callus, these calyces, normal cupping of the calyces. You see these cups? This is normal cupping of the calyces. This is known as clubbing of the calyces. So when you have clubbing, that means the calyces are dilated. There is dilatation of the collecting system. This is compare the normal cups with the clubs. So this is abnormal. Okay, so sometimes you could also have stones like this. This is a plain film. It's not a contrast study. And this is a staghorn calculus. So the stone takes up the shape of the collecting system. So it looks like as if there's excretion of contrast. Actually, there is no contrast. There's no contrast given. It's just that the stone is taking up the shape of the renal pelvis and the calyces. So it looks like a staghorn, horn in a deer. It's named after that, Staghorn calculus. Remember, on the right side, sometimes you could think that these are renal stones. Remember, the gallbladder also has stones. And as I've said, although they majority are cholesterol stones and are not radio opaque, but some stones can be opaque if they are having some calcium deposition. So this is actually gallstones. So remember, the gallstones can mimic renal stones on the right side. But obviously on the left side, if you see calcium, it's going to be renal stones. There's nothing on the left side which can mimic renal stones. Okay, case 2 is middle-aged female with the fever and high WBC count. So what's wrong with her? Infection. So she has infection. So how does infection look like on ultrasound? The cortex, you would see that it becomes echogenic. Some part of the cortex becomes echogenic. So this means that she has pyelonephritis. So pyelonephritis can be unilateral, bilateral, or can be focal. So this is focal pyelonephritis, nephronia. Some part of the kidney is abnormal. And if you do a CT scan, you will see that the nephrographic phase, where you should have symmetrical enhancement of the cortex and medulla, you'll see that some part of the cortex is not taking up contrast. So you'll have a sort of striated pattern of enhancement here. Compare it with the normal homogeneous enhancement pattern in the rest of the kidney. Compare it with the normal pattern on the other kidney. So this is focal nephronia or focal pyelonephritis. So pyelonephritis, acute pyelonephritis, has a striated nephrogram. Remember, the kidney can become swollen. It can become swollen. It can have poor renal function. Urea creatinine levels can become deranged in acute setting. And on CT, you would see that the fat around the kidney becomes dirty. So perinephric fat stranding is there. Now, the thing is to treat them urgently, because if you don't treat them, these patients can develop hypertension and go into renal failure and even renal scarring. Okay, so we don't want that to happen. That is why we have to aggressively treat them with antibiotics. So striated nephrograms, again, showing you both kidneys being affected. You see these triangular sort of striations. You see these triangular sort of striations. Some part of the kidney is enhancing, some part is not enhancing. So this is known as striated nephrogram. Whenever you see a striated nephrogram, remember, it's going to be pyelonephritis, acute pyelonephritis. Again, striated nephrogram, acute pyelonephritis. And if you don't treat them, then they would develop scarring like this. So the kidney becomes sort of smaller in size, loses nephrons, and becomes lobulated like this. You see the lobulations, you see the kidney becomes lobulated. So now there is scarring in the kidney. The kidney has lost some of the functioning nephrons. This is how the chronic pyelonephritis looks like. Now, another problem with the pyelonephritis is if you don't treat them, they can also develop abscesses. So there are different types of pyelonephritis. Emphysematous pyelonephritis, xanthogranulomatous pyelonephritis. Emphysematous means air inside, and xanthogranulomatous means fat containing macrophages. Okay, so you can have abscess inside a kidney like this. You can also have abscess outside the kidney with a renal stone displacing the kidney anteriorly. You see, doesn't look a normal looking kidney. There's an abscess behind in the retroperitoneal space, which is displacing the kidney anteriorly. So this is outside the kidney abscess. This is inside the kidney abscess. And these are examples of pyelonephritis is different. Emphysematous, air inside, air inside. You see, this is air inside. The black is the air. And xanthogranulomatous means fat inside. You see, this black is the fat, and this is the stone. So remember, the xanthogranulomatous is also a chronic pyelonephritis, usually associated with stones. And the kidney does not take up contrast because it has lost its function and is replaced by macrophages, which are laden with fat. So that is why the name is given xanthogranulomatous. Okay, are you clear on this? How to differentiate? We've discussed acute pyelonephritis, striated nephrogram. Don't treat them, they go into hypertension, scarring. Scarring would be loss of nephrons and outline lobulated. The patient can also develop abscesses. They can also develop pyelonephritis, different chronic sort of pyelonephritis. One is emphysematous, which has air inside, and the second one is xanthogranulomatous, which has fat containing macrophages, fat cells. That is why it would be like this, dark colors, okay? But it would not be jet black like this, like the air inside. And usually it is associated with stones because the stones are there for some time and they are resulting in obstruction. So there'll be no enhancement of that kidney as well. Poor functioning kidney. Yeah.
How do you differentiate them from granulomatous and kidney, like,
Between xantho and tumor. Tumor would enhance. Xanthogranulomatous kidney is non-functional kidney. It will not enhance. Okay. So this is a kidney again, xanthogranulomatous. It is not enhancing. See, it's not enhancing. This is a kidney where there's an abscess inside. You see air inside. There's a speck of air here. So this is abscess, and look at the fat around it. Perinephric fat stranding. Okay. This is infarct. Remember, don't mix up the infarct with pyelonephritis. Striated nephrogram means triangular sort, some patchy sort of enhancement. Some part of the kidney would enhance, some would not enhance. Infarct means when the kidney doesn't enhance totally like this. It can be whole kidney, it can be part of a kidney again, and it is going to be at the periphery of the kidney. So you have to be a little careful when you call it infarct or striated nephrogram. Now, this is another kidney which is almost non-functional. It is known as putty kidney, seen in renal tuberculosis. So the kidney becomes small, atrophic, and gets totally calcified like this. So since it's a granulomatous disease, it is replaced by calcium. So it's a sort of autonephrectomy. Again, small kidney like this, not to mix this up with nephrocalcinosis. What is nephrocalcinosis? Calcinosis means calcium deposition. Nephro means kidney. So deposition of calcium inside the kidney is known as nephrocalcinosis. So what type of nephrocalcinosis do you know of? Do you know of any calcification inside the kidney? Conditions? Have you heard of medullary sponge kidney? What is medullary sponge kidney? Anyone? Yeah, it's cystic disease of this. Actually, the cysts that you are referring to are these the collecting system inside the medulla and the papillae. These cysts, the collecting system are dysplastic, and they get dilated, and that is why they give appearance of cysts. Actually, they undergo calcification because they are dysplastic collecting system inside the medulla. That is why you have these calcifications inside the medulla. You see, the cortex is spared here. The cortex is spared. You have calcium deposition inside the medulla. There are different conditions which can affect calcium deposition inside the medulla, like hyperparathyroidism, milk alkali syndrome, hyperthyroidism, medullary sponge kidney. They all result in medullary calcification. There are a few conditions like poisoning, like drugs, like chronic glomerulonephritis, snake poisoning. They can result in cortical sort of calcification. So it depends on where the calcium deposition is. So this is medullary sponge kidney. The cortex is spared, and the medulla, the inner part, is more calcified. And you have these tiny cystic areas like this on CT, giving you a sponge-like appearance. So cystic tiny areas. These are actually the dysplastic collecting system inside the medulla. Okay. Again, medullary sponge kidney. Yes, this one. Yeah. No, it depends on it. Unilateral means it doesn't mean that if it affects both kidneys, obviously it's going to be bilateral. Here it is affecting, it is resulting in destruction of entire kidney. The kidney becomes non-functional. In medullary sponge kidney, the kidney is still functioning. No, it doesn't matter. If kidney affects both kidney, obviously it will result in putty kidney on both sides. But usually it is going to be one kidney at least. Okay, tuberculosis can affect any organ from head to toe. It can affect any organ. So it's one disease that can affect any organ anywhere. Understand? But remember, there's going to be small, entirely calcified, non-functional, and the appearance would be something like this. It would not have a typical cortical or medullary calcification. So the reason for showing you this is how to differentiate it from medullary sponge kidney or medullary calcifications. Understand? Not to mix them up. Putty kidney means the entire cortex and medulla both are involved. If nephrocalcinosis, it can be medullary, it can be cortical. Understand? If it is both, is more likely to be putty kidney, and it's going to be non-functional. Clear? So this is medullary sponge kidney. Just the medulla getting calcified, the medullary part. Okay, the last case, young female presenting with decreased renal function, high urea creatinine level. Okay, so what do you think it is? Polycystic. So renal function is going to be abnormal in polycystic kidney disease. You see, both kidneys have multiple cysts of variable sizes. See, both kidneys, there are also cysts inside the liver as well. So it's a syndrome. It affects the kidneys, the pancreas, and the liver. You do the ultrasound, you will not be able to differentiate between the cortex and the medulla. So this is not normal looking kidney. And MR also, you will see that some cysts are abnormal shape. They would also have inside hemorrhage. They can also have calcium, stone deposition along with polycystic disease. So these patients are more prone to have hypertension, aneurysm, aneurysm. So depending on what type of polycystic kidney disease it is. In adults, it's an autosomal dominant sort of condition. And in children, it is going to be autosomal recessive. And the cysts are going to be small in size. But the problem in children is that they're not going to survive in a later age. So it is fatal and they die early on. In adults, the cysts can get larger in size and they go up to even middle age. But they usually develop other complications like aneurysms and hypertension. Okay, a few congenital anomalies. This is a pelvic kidney. This is a subdiaphragmatic kidney. So these are abnormal location of kidneys. This is a crossed fused ectopia. Cross means that it has gone to the other side and has fused with the kidney that is there. So crossed fused ectopia. But remember, the collecting system remains and opens on the same side. So the ureter will open on the left side. And this is horseshoe kidney. So both kidneys are united at the inferior poles. They'll be united in front of the spine. So this is known as horseshoe kidney. These are the common sort of congenital anomalies that you see. Another anomaly that you would see is absence of a kidney. Agenesis means no kidney. Congenitally, there's no kidney. Hypoplasia means small kidney since birth. Hypoplasia, a small kidney. There'll be some function in it. This one has a cyst in it, so don't mix it up. This is also an abnormal kidney, but it has a cyst. Okay, but this one is hypoplastic. So this is intrathoracic kidney, inside the thoracic cavity. This is cross-fused ectopia. Okay, the kidney has gone and fused with the other side. The left kidney is here and the right one is lying here. So you have two collecting systems. The collecting system of one, it will open on this side. This is pelvic kidney. Okay, this is horseshoe kidney. Clear on this, everyone? Yes. Which one? Yes. They are totally functional. They just cross over. It's just by nature they lie on the other side and they are just united. Just like these are united in the lower part, they are also united. So they're just lying one over the other. This one? No, it's not transplanted. It's the left kidney is not there. So congenitally, it's an ectopic kidney lying in the pelvis. Like you have this in the thoracic cavity, it's lying in the pelvis. But it's a good observation. The transplanted would also be lying somewhere here. But you would see the native small kidneys here. You would see atrophic small kidneys of the person getting the transplant. Okay, so what is this? Horseshoe kidney. Remember, the collecting system are abnormal. So these are more prone to have obstruction and stone formation. The high horseshoe kidneys, the collecting system are lying anteriorly. That is why their shape is something like this. They are more prone to stasis, more prone to have stones, and they also have chances of developing cancers. What is this double collecting system? You see renal duplication, two pelvises. Okay, this is attempted duplication. This is PUJ obstruction, pelvic ureteric junctional obstruction. This can be congenital as well. So they can be hydronephrosis because of narrowing at this part, pelvic ureteric junction. The narrowing at this part can result in PUJ obstruction. Sometimes a vessel is sort of obstructing or passing this point, and it is resulting in obstruction. Okay, now let's test your knowledge. What is this? Cross-fused ectopia. You see the ureter on this side is going to this side. Okay, what is this? Yeah, ectopic kidney lying lower part in the pelvis, slightly above the pelvis actually. What about this one? double collecting system on both sides. You see two ureters here, two ureters here, and there are these filling defects inside the bladder. These are ureteroseals. So the part of the ureter which is lying inside the urinary bladder, they also get dilated. So these are sometimes known as ureteroseals, dilatation of that intravesical part. So this is renal duplication on both sides with intravesical ureteroseals. So ureters just get dilated. What is this? Horseshoe. Remember the horseshoe kidney, as I've said, it's an abnormal orientation. Those are the pelvises come anteriorly. So that is why they get dilated like this. So more chances of stasis and hydronephrosis, more chances of stone formation and infection. This one, this is the kidney here, ectopic kidney. Okay. And this is cross-fused ectopia. This is renal duplication with intravesical ureteroseals. Okay. Okay, so the fourth case we'll discuss next time because since we're already 5 minutes ahead, so this I'll put up with the next lecture, okay? So obviously it's going to be with the tumors, so we have to differentiate. Just read about Bosniak classification. Have you heard of Bosniak? It's an American, who gave this classification, I guess, in 1986 about renal cysts. He died about 2, 3 years back. So he is the one who classified these cysts of kidneys. It's very commonly used these days. They have sort of given a new addition to it once the MR and CT is there. But by far the common things I'll discuss next time. So how to differentiate abnormal cyst with a tumor, because some tumors can be cystic as well. So we'll discuss this next time. Okay. Thank you very much. By the way, the email is there at the end. You can email me.